Dr. Sushmita can start with her.
Please.
She'll be presenting on subretinal hemorrhage with RRD in IPCV. Please upload the presentation here. Or you can go there, whatever.
Good afternoon, everyone. I'll be presenting a case on rhegmatogenous retinal detachment with massive subretinal hemorrhage in idiopathic polypoidal choroidal vasculopathy. So, 84-year-old male presented to us with sudden onset loss of vision and floaters in left eye since 15 days. The patient was a known case of diabetes and hypertension. He had undergone both eye cataract surgery 10 years ago. He was a known case of bilateral IPCV, which was confirmed on ICGA. The ICGA of left eye, here you can see a single polyp, whereas the ICGA in the left eye showed multiple polyps along with the subretinal hemorrhage. The fluorescein angiography in both eye revealed RPE window defects. The patient received multiple anti-VEGF injections and focal laser in both eye. 1 year later, the patient presented to us with a BCVA of PL positive, PR accurate in left eye. USG was done in the left eye. It revealed numerous small size vitreous echoes with retinal detachment. On fundus examination, here we can see the left eye vitreous hemorrhage. So a provisional diagnosis of left eye retinal detachment with vitreous hemorrhage in a case of bilateral IPCV was made. A 27 gauge transconjunctival sutureless vitrectomy with removal of the subretinal blood, fluid air exchange and injection ranibizumab with silicone oil infusion under LA in left eye was planned. Here in the surgical video, we can all see that the core vitrectomy is being performed. After which, bullous RD along with the subretinal blood was noted. Thorough inspection of the peripheral retina was done, and a tiny flap tear at 2 o'clock temporal periphery was noted. From here, removal of the subretinal blood was done using the active suction of 27 gauge cutter. As the break was located in the extreme periphery, complete removal of the blood was not possible. Therefore, we made a retinotomy inferonasal to the disc, and from here the remaining subretinal blood and fluid was removed from the posterior pole. Here we can see the remaining subretinal blood is being removed, and the retina is getting settled over here. It was then followed by fluid air exchange, which was then followed by endolaser around the retinotomy and the primary retinal break, which was followed by injection ranibizumab and silicone oil injection. So post of 6 weeks, the OCT revealed thickened scar and overlying thicker retina with subretinal fluid adjacent to the scar, and the fundus showed traces of hemorrhage adjacent to the scar. Post of 5 months, OCT showed resolution of the subretinal fluid and reduced retinal thickness, and the fundus showed resolution of the subretinal hemorrhage. This is a very unique case because of combined rhegmatogenous retinal detachment with massive subretinal hemorrhage, which did not require any fibrinolytic agent for liquefaction. Subretinal blood could be removed completely, almost completely. IPCV is very similar in presentation with neovascular AMD, but it is characterized by massive submacular hemorrhage, and ICGA is the best diagnostic tool for it. Patients presenting to us with features of AMD and showing suboptimal response to anti-VEGFs must be evaluated early and promptly to rule out IPCV to prevent irreversible vision loss. Thank you.
Why did you use ranibizumab? Why didn't you use brolucizumab or aflibercept?
So already we used brolucizumab and aflibercept, and we gave multiple anti-VEGFs injection earlier. So the patients...
No, it's not the first line of treatment. The choice of anti-VEGF in PCV is either aflibercept or brolucizumab.
Yes, sir. We initially gave it in the trial, but during the surgery, the patient requested because already it was not affordable for the patient.
Second thing, why do you think there was liquefaction of the subretinal blood?
Sir,
usually not there when the retina is
yes, sir, because there was a rhegmatogenous retinal detachment, which lead to the leakage of in the subretinal space. The fluid leaked in the subretinal space, which led to the liquefaction. Like the blood was not clotted.
And what was the time period from subretinal hemorrhage to the intervention, surgical intervention?
So,
because lysis will only occur after 2 weeks of bleed.
Yes.
So what was the time period for that?
So from the diagnosis to the intervention,
Yes.
sir, earlier we gave the antiviral.
In your case.
Particular case.
So 1 year.
No. The time period between the subretinal bleed
Blood.
and your intervention.
Your intervention.
Oh, it was more than 2 weeks, sir.
Yeah, that is the time.
Yeah.
2 weeks is the time when the lysis of
Lysis
blood
of blood
occurs.
occurs.
That is one of the reason you didn't require tissue plasminogen
Tissue plasminogen
activator,
activator, sir.
and the blood came out only with the cutter.
Yes, sir.
So I have another question. Your first clinical image that you showed had peripheral subretinal hemorrhage, right? In the inferior temporal cortex.
In the left eye.
So why isn't this a case of Pecher? You had a peripheral subretinal bleed. Although it falls in the same
category.
but still it is a distinct entity. I would have probably labeled it as Pecher to begin with.
Because does not look like after settling of the retina.
So
It's one and the same thing. Peripheral, it's a polyp only.
Yeah.
So it's a one and the same thing.
it falls in the same pachychoroid spectrum.
Yeah, pachychoroid.
Nice case.
Thank you so much.